and welcome to Stanford Med Matters. I'm Dr. Ruth Adewuya, the Managing Director of the Stanford Center for Continuing Medical Education and the host of Stanford Medcast. Today, we will discuss the emerging and highly pathogenic avian influenza A virus, also known as the H5N1 virus. Joining us is Dr. Abraar Karan, an infectious disease fellow and postdoctoral researcher in the Stanford Division of Infectious Diseases and Geographic Medicine. Dr. Karan worked on the COVID-19 outbreak with the Massachusetts Department of Public Health and the monkeypox outbreak with the Los Angeles County Department of Public Health. He also served on the WHO-commissioned independent panel on pandemic preparedness and response research team. Dr. Karan specializes in infectious diseases, emerging pathogens, and zoonotic infections in his clinical practice. Dr. Karan, thank you for joining us today.
Thanks so much for having me.
Let's just jump into the questions that we have today, because there's a lot to unpack here. And to start, can you briefly explain what the H5N1 virus is and how it differs from other strains of avian influenza?
Definitely. So H5N1, the H and the N refer to the surface proteins, the hemagglutinin and the neuraminidase, and these are what are characterized, in terms of figuring out what type of flu we're dealing with. So we've got flus that primarily infect humans, the ones that we see through the, throughout the year, every year, and then we've got flus that primarily infect other animals, and bird flu is one of these. So typically, there are sort of 5 subtypes we think of: H5, H6, H7, H9, and H10. And we think about bird flu in both high and low pathogenicity. So the low pathogenicity strains, they don't really cause too many symptoms in poultry, or the symptoms are mild. And then you've got the high pathogenicity, and these cause more severe disease and death, greater than 90% often within a couple of days in birds. And we have these circulating kind of throughout the year, throughout the world, in different forms. So the current clade or sort of group that has been circulating is 2.3.4.4b. And I know that's a mouthful, but essentially this was a clade that was identified in wild birds that were sampled in the US in late 2021, although something similar had been circulating globally even in 2020. It's caused bird outbreaks in several states, most states around the US. And so we've been dealing with this in poultry for a few years already. H5N1 and H7N9 are the viruses that have caused most of the avian influenza viruses that actually have been reported in people, but there have been a few others as well.
According to some of the recent reports, H5N1 has been detected in various bird populations across the US. What are the implications of these detections for public health and poultry farming?
So the implications are essentially that when you have these kind of viruses circulating in poultry, like it can make your bird sick, and it requires that these birds be culled. So other birds in the flock that before they get sick also have to be killed. And there's financial models in place to sort of help the poultry farmers deal with this. Poultry farming is kind of interesting because you've got both producers such as the sort of big players like Tyson Foods, and then you have growers who are basically contract workers that grow the poultry and then they give them back to the producers. And so these people that are growing poultry on the front lines essentially are exposed to birds that are packed into very, very tight spaces. And there is a risk for infection if you're not using the right personal protective equipment like masks and eyewear. So this is always the issue with sort of zoonotic diseases where you've got increasing human and animal interfacing, where like people are near animals. As infectious disease doctors, we are aware of many, many different types of infections, but broadly speaking, these are problematic because they're viruses that mutate quickly and rapidly. And we are worried that this could turn into something that's, much deadlier at any point.
Help us understand the scope of this globally. What is the current status of H5N1 outbreaks globally? Which countries or regions are most affected by H5N1 right now?
So there's H5N1 broadly, right, where we see different settings, Southeast Asia, South Asia, India, Bangladesh, other countries where there's a lot of live sort of poultry markets, Southeast Asia, Cambodia, Vietnam. Then you've got the outbreak that's happening right now in the US, and we'll talk more about this, but this is a particularly unique outbreak in that dairy cows got infected. And this is the first time that we've seen it in dairy cows. This started in March of 2024. And before this, since 2022, 200 different mammals in the US have been infected with highly pathogenic avian influenza. But this was the first time that it was found in dairy cows. And that's particularly problematic for a few reasons. So one of the reasons that's an issue is that we have close contact with cows, with with dairy farmers who are working with these cows. So there's an increased risk of that going into humans. And the milk supply is the other big one. So, can cows shed virus through the milk? The answer to that is yes. What risk does that pose to the public? That was sort of a big question, given that, there's so much consumption of dairy in this country.
Yeah, absolutely. You've alluded to this, the unique thing about dairy cows and talking about how has the detection of this virus in dairy cows impact our understanding of the virus's transmission and the risks around that.
Yeah, it's a good question. So April 1st was the first case where a human was infected, and this was the first mammal to human case documented. So it's from presumably from cow's milk to human. The thought was then there was a lot of investigation done to figure out how this may have happened. And this was the first case, but there were a few other cases, and primarily we found that patients had conjunctivitis. So the thought was that some cow milk may have splashed into the eye of a dairy cow worker, which can happen when I'm not a dairy cow worker, but looking at interviews that have been done on sort of the front line of what's going on there. There is a lot of equipment that's used where milk does get splashed around, it gets onto surfaces. So studies were then done to say, okay, does the raw milk of cows have viable virus H5N1 in it? The answer to that was yes. Then studies were done looking at sort of the milk itself on surfaces, and how long was that viable? And the answer to that was, several hours, if not longer than that. And so that was a feasible route of transmission. Where did somebody touch some milk, without gloves and then touch their eye? Did some splash into their eye if they weren't using eye protection? Or sometimes what can happen is, liquids can actually get aerosolized. So could someone have breathed it in? So those are all potentials. Then investigations were done to say, okay, well, we haven't really thought about dairy cows as a host for this virus before. So is there something particular about so if milk is getting infected and the milk looked different, the cows weren't producing as much milk, they were actually sick. So then investigations are done looking at the type of cells that are present in cow udders. And what they found was that the receptors that are used for binding, what the virus uses to bind into cells, both the type that's present in chickens and poultry, the avian receptor is called the sialic acid alpha 2,3 receptor. The human receptor is the 2,6 receptor. Both of these were actually present in dairy cow udders. And so that, is problematic because now you have a virus that's sort of hanging out in there. That virus continues to mutate and adapt. And so a lot of worry now is on the way that the virus is evolving, the way that it's adapting, and what mutations is it developing, especially when you don't have this outbreak under control. So if it continues to spread amongst cows and it continues to evolve and mutate, does it eventually gain the mutations that it needs to effectively bind to human cells, so human respiratory cells? And there was some experiments done already with some of the strains that are present that showed that, yes, actually, in laboratory settings, they were able to bind to human respiratory cells. So the virus is already evolving in that direction. Then the question thereafter becomes transmission between humans, right? So that's what you really worry about for epidemic-prone infections, respiratory transmission that's communicable between humans. The mammal to human, we now with this outbreak with cows, we have seen that that has been the case. There have been multiple workers infected over the last several months. I think the total count, if I'm not mistaken, right now is 13 cases since April 2024. Some of those were thought to be from cow to human. Some of those were thought to be from poultry to human. And I'll talk about what happened with the poultry cases recently. So that's one part of it. The other part is that there have already been studies from prior cases of H5N1 where there has been documentation of very likely transmission between humans. So the way that that's done, so a few examples of this. So 1997 in Hong Kong, that was the first human case of highly pathogenic avian influenza. They did sero studies where they took blood samples and looked for antibodies amongst workers and household contacts that had exposure to cases, and they found that they did have antibodies. So there was likely transmission. 2003 in the Netherlands, there was H5N1 from poultry workers to family members. They also did studies finding that. There's 2004 in Thailand, they found an ill child likely transmitted H5N1 to mother and aunt. And there's many, many other examples that have been documented. The other point to make is historically H5N1 has been a very, very deadly virus when it goes into humans. So like the mortality rate has been 40 to 50%.
Wow.
But the clade that we're dealing with right now, the one that I had mentioned, is slightly different in that this sort of subclade has not yet caused very severe disease amongst humans. All the cases we've had have been mild with conjunctivitis and flu-like symptoms. But the concern is that, it's still part of a type of virus that has been known to be very deadly in humans previously.
Actually, that's a great segue to this issue that clinicians might have to face when faced with a patient coming in with some symptoms. How might they distinguish these symptoms from this type of influenza and the common cold?
Yeah, so common cold caused typically by various seasonal coronaviruses, and then you've got flu, which typically we have flu A and flu B in humans, and essentially those flu-like symptoms many of us are very familiar with, fever, fatigue, body aches, runny nose, coughing. So those symptoms are going to be actually very, very similar. The way that we as clinicians and frontline providers are going to be helpful is actually going to be on the history taking and the epidemiologic exposure. So we can run through what those are right now. So, when you start with an outbreak and you figure out like who you want to test, what you're dealing with, you have to have a case definition. So like, what does a case actually mean here? Especially before you, you have probable cases and confirmed cases. So probable cases are those who we want to test and get, microbiologic confirmation that they've got whatever pathogen we're considering. So the CDC's current epidemiologic criteria are as follows. So close exposure within 2 meters to infected birds. So birds that, or poultry, and that can be in, commercial settings, wild birds, there's people that hunt birds, or people that have backyard operations. So this is going to, or workers that are in these commercial, larger, operations where they do growing or culling. The tricky part here is actually that it's hard to know if it's actually confirmed infection, because to confirm infection amongst the birds, that means that the testing had to be done. And, I can talk a little bit about what those surveillance programs and testing programs look like. So that's one. So like basically very close exposure to known infected birds. Direct contact with contaminated surfaces in these settings. So like if you're cleaning or touching, or if you like touched bird poop, or if you've been around an area where there's like a lot of feathers and other and bodily secretions from birds, or if you visited a live poultry market that has confirmed infected birds. So like, even in San Francisco recently, within the last couple of months, there was confirmed H5N1 in birds at a live poultry market, no infections amongst workers. Or if you have exposure to an infected person without using adequate personal protective equipment. So if you're not using eye protection and respiratory protection. So those are the epi criteria, but they are a little bit tricky because they kind of call for, if they had a confirmed exposure to like a known infected bird. I would actually broadly say that, that is going to be a less useful criteria. A more useful criteria for us is going to be asking patients, if they've been on farms, if they've been near birds generally, if they've been near dead birds generally, even without confirmation that it's H5N1 at this point. If they come in with flu-like symptoms and they've had, you would want to ask about these kind of exposures. So what happens then after that gets done, you would test them. And so most of our tests right now will just be, depending on the setting, if you're in urgent care, you're going to be using certain testing mechanisms that will test for flu A, flu B, and RSV, for example. Like it'll give you kind of all three. There are point of care tests which are just done in the clinic, and then that's it. There's other tests where we're swabbing, we put it into a viral transport medium, and then we send it off to the lab. So then what happens? So what happens then is basically the lab, if the lab gets a positive sample for flu A, they do what's called subtyping. So a subtype to say, okay, what kind of H and N groups does it have? But the current tests for most of these tests are not running for H5N1 because that's not something we typically see. And so it returns as untypable. So when you have an untypable flu A, you're supposed to send those samples to your state public health laboratory, your local public health lab, or the CDC lab, and then they will subtype it to say, is this H5N1? That's what's happening right now. That's what is going on. I do some shifts down in San Jose in urgent care settings where I'm constantly seeing patients who have all kinds of stuff coming in. And that's sort of the protocol that's being used. Stanford, we are very innovative here, and we've got, some of the best in virology and microbiology. So we often have our own in-house tests that are made. And so we have a research test that has been developed and published on that's an H5 assay, by the clinical virology lab here. So that's a little bit of what happens in like the real world setting, right? So you've got your epi criteria, and then you've got your clinical criteria where you're like, okay, they kind of look like they've got flu. I want to make one other comment, which is essentially that it's much easier when you have a patient that's very, very sick, they're hospitalized, we're testing them for all kinds of stuff. This is a little bit different in terms of the outbreak. The reason that it's different is because many cases are mild, and mild cases in an outbreak become very, very tricky because they slip under the radar. And I'll give you an example of why that is. So in a typical urgent care setting, you get patients that come in, a lot of COVID circulating right now, less flu right now, but we're going to be heading back into human flu season soon. Patient comes in, if they look okay and they've had symptoms for more than 4 or 5 days, many clinicians are not going to test them for either COVID or flu because they'll say, what's the point? There's not anything we're going to offer you because you're already out of the window for treatment or you're near that. And so just go home and come back if you don't feel better. So they never get tested. And so when you have something like bird flu where it's mild cases, imagine if we're depending on a clinical surveillance system that's like, clinicians or NPs or frontline providers doing testing, getting a flu A positive sample, subtyping the untypable sample with H5 assays. That's probably not going to happen for the most part. And I've talked to clinicians on the front. I mean, I am a frontline clinician, and I've also talked to colleagues who are not thinking about this and are not doing it. And so that is very problematic. The other case where it's like, oh, someone's very sick in an ICU, yeah, they will get all the testing done. So I'm not as worried. So I'll stop there, but we could talk a little more after.
I appreciate how you laid out what the process from the diagnosis and what clinicians can look for in terms of symptoms to the testing that is done. Yeah. And you talked about how there's some advancements even in diagnostic testing. Would you be able to share a little bit more of what the test that's happening at Stanford that is a little bit more innovative and the research that you're doing there, and talk about how it differs from what's currently available?
Yeah, so this test, I wasn't involved with the development of this test, but I work closely with the lab. I'm more on the field and epi side of things. But the way it sort of would work is, so, internally Stanford has developed an H5 assay that essentially could test any kind of samples and say, is this H5N1? So that's a test that they've developed. They've internally validated using, older H5N1 samples and also samples from the current outbreak, some of the genomic sequences that are available publicly. And they've tested this to say, okay, is this an accurate test? Does it work well to identify accurately people that have, if they had H5N1? So what would then potentially happen is, some parts of our state, we've got, great public health labs where, you've got integrated systems. So in San Jose, we have our county system, and the county urgent cares, you get samples, and there's this nice system in place where, those flu positive tests get sent to the county, the San Jose lab and the state lab, et cetera. But in other settings, that may not be happening. So, if you look at more rural parts of our state, some of those positive samples, especially if they're kind of more commercial urgent cares or commercial clinics, those flu positive samples may just end up as flu positive and they never get subtyped, and someone would just be told, yeah, you have some kind of flu, and that's the end of it. So one operation that could be interesting is actually pulling in some of those samples and having a research lab like Stanford help to run this type of assay on those samples. And that's particularly relevant because we know the exposures to dairy and poultry and whatnot, they are happening in kind of more rural settings where you have people that are on farms. And so that's not necessarily going to be captured in the city. So I think that could be one interesting place where Stanford could really help. And this is a big issue. So having access to diagnostics quickly is a big problem. We saw this during COVID when we didn't have tests initially. So being able to develop in-house tests and get those tests done, it's also a matter of speed, right? It's also a matter of data sharing and having access to data that otherwise may not be shared. Sometimes when you work with state or CDC labs, because the tests are not often CLIA approved, meaning they're not approved for clinical decision making. Sometimes you don't get all the results back that you need from those tests, which can be a little bit tricky for clinicians in terms of like, what do I do with this information? So there's always, decentralizing these diagnostics and making sure like places, academic centers, hospitals, clinics, that they could run these tests in-house. That's very, very important for epidemic response because it quickly tells you what the patient has. It helps you with isolating them and getting, the adequate clinical the treatments, in place. So it's a huge accomplishment to have an in-house diagnostic. Very few places have it. Stanford is one of the very few ones, and that was just published recently.
That's really exciting. And you're right. Obviously, we hope that we never get to a place where there is this global health issue, but it's great to hear that there are incredible people working on things that will support such a situation. You set the stage for us and talked about the diagnosis process, how the symptoms that go with it. Let's talk about treatment options. What treatment options are currently available for humans should they be infected with H5N1? Are there any antiviral medications or therapies that have shown promise in treating this infection?
Yeah, definitely. So, when you think about flu antivirals, you have a couple of classes. So neuraminidase inhibitors. So that's like your Tamiflu, like oseltamivir, peramivir, zanamivir. And then there's cap-dependent endonuclease inhibitor, baloxavir. So there's no randomized clinical trials of these medications for H5N1 or for any of the novel rather than seasonal influenza A viruses. But there's observational studies showing benefit where patients seem to get better on these. There's studies in laboratory settings to understand, like, do these work mechanistically and do these work outside of patients? There's been studies actually even done just within the last few months saying, how do these medications, do they still work well with the sort of mutations that are seen in the H5N1 virus right now? One study that I saw essentially, not in patients, but just it's a sort of a laboratory-based environment, found that oseltamivir worked slightly better, is better tailored to the current virus strain that we're dealing with versus the other neuraminidase inhibitors. And I believe that the patients that we've had that got infected already with bird flu during this outbreak right now were given oseltamivir, and they've all done fine, they've all recovered. So That's what we have right now, but we don't have big clinical trials. And we often don't for epidemic-prone infections that, have, rare spillovers. We just don't have the numbers to run like a big study.
And are there any vaccines that are in development for H5N1? And if not, how effective are any of the existing vaccines for H5N1?
Yeah, so they're always sort of candidate vaccine that are in place. So there's H5 candidate vaccine viruses that are very, very similar or identical to in terms of the hemagglutinin protein that is present in the current circulating strain. So the government for months now has been already working on stockpiling some amount of vaccine. And then the question then becomes, well, we don't know. We know in terms of like how well these vaccines produce neutralizing antibodies. So in theory, how well they could work. We don't have, again, like large scale studies like we do with COVID because we don't have that level of human infections to know like actual vaccine effectiveness or efficacy. But we usually don't have that for these type of infections anyway. So you're basically saying like, is it similar? Does it induce an immune response? So yes, there are vaccines available. Many countries in Europe, for example, have already ordered vaccines. Finland, in particular, has actually already started offering and I believe rolling out vaccines for poultry workers. In the United States, there's actually another strategy that's now CDC is pushing, which is that they're trying to incentivize poultry and dairy and other farm workers to get the seasonal flu vaccine. They've just infused several $1 million to push out a program to make sure that these 200,000 workers that fall in this category get the seasonal flu vaccine. The reason is that it's sort of a ticking time bomb right now because we have likely now endemic H5N1 amongst dairy cows and poultry that have close contact with humans. And when you get a human or a cow or a pig infected with both the seasonal human infection, human like H3N2 or H1N1, like a human flu infection, and you also get an infection with bird flu, you can have viral reassortment. So they start swapping genetic material and it becomes like a mixing pot or a vessel for a potentially very bad virus to emerge. So we really don't want those co-infections. And so one way they're trying to tackle this is to really push out the sort of seasonal flu vaccine to these workers. There's a lot of debate, though. There's a lot of debate about, should we actually be vaccinating these workers right now with the targeting H5N1?
Is it because of a lack of the availability?
It's not an issue of availability. Like we've got stockpiled vaccine, we can obtain more. The issue actually is it's a constant risk assessment. So they decide on should we go ahead and do this? They may be weighing, well, we've only had 13 cases amongst humans. Let's still focus on getting this under control in dairy. Let's work on other aspects of the response. And we can talk about maybe a few key things that I think should happen, but I think that's constantly just weighing risk.
Curious to hear from you what lessons we can learn from past influenza outbreaks, such as the H1N1 pandemic of 1918, in preparing for a potential H5N1 pandemic.
Yeah, it's a great question. I was thinking about both this and then also lessons learned from something far more recent, which obviously is COVID. So there's a lot of aspects of it. So, on the one hand, how do you actually get infected? You get infected by, breathing in the virus or touching something and getting your hands contaminated and then ingesting that or touching a mucous membrane. So on a very basic level, a big takeaway is better personal protective equipment at the front line. And I know this sounds sort of simple, like, oh, just wear a mask or wear gloves or wear eye protection. But actually, the working conditions are very tough here. So when we had this recent spillover into workers in Colorado, it was described as the heat was over 100 degrees Fahrenheit, very cramped indoor conditions. And so workers took the PPE off. And despite millions of dollars being put into this pandemic, this bird flu response, a very simple thing like PPE was where we had a spillover and we had a breach in the security. So I think at a very basic level, PPE is going to be important, and it's very tricky because people don't want to wear masks right now. People don't want to wear the right type of mask. We don't have fit testing at a broad level in case we are starting to deal again with an airborne virus. If that happens. So that's one. Public health communication is going to be huge. I think just like you said, like communicating what the risk is to the public. There's always stuff going on. We had monkeypox. We have all kinds of outbreaks going on overseas. And so communicating effectively where the public is like, do I really need to worry about this right now? So there have been some key messages like don't consume raw milk, because there are a number of people in the country that consume raw milk as a product. It's also sold commercially in sort of big retail stores. So that was important, figuring out like the milk supply issue, the virus in the milk, communicating not to drink raw milk. Actually, despite that, raw milk sales went up. So that, again, just that's very tricky, communicating, understanding the implications. People had misunderstandings saying, I'll drink raw milk so I get immunity. So that's another aspect. Then you've got sort of the the strategy around antivirals. How many do we have to have on hand? The strategy around vaccines. Who do we vaccinate? How much do we stockpile the vaccine? And then it's the other broad problem in the U.S. is that we have a state by state response. So we're really just a very fragmented public health system, and we don't have a health system that's really focused on or a lot more could be done for people that are low income, that are outside of cities and working in these rural areas. We just don't have great public health systems set up in those settings where like these spillovers are going to happen. The other thing is it's a very complicated outbreak because it really relies on One Health. One Health is essentially where you have, it's an approach that takes into account veterinary sciences and animal health, human sciences and human health, and then environmental sciences and environmental health. So this, more than even COVID, is really a One Health outbreak where you have, dairy cows and poultry. You've got milk supply issues. You've got the human infection issue. You've got movement of milk and dairy cows across state lines. So there's so many components, and what that means is you've got a response from the CDC, the FDA, the U.S. Department of Agriculture, the Department of Defense. So there's so many agencies that are involved in this, even more than probably were involved with COVID. So that's very tough, and coordinating that kind of response is very, very complicated. So I think like, those are some broad issues, and they're very similar issues that are things that came up during COVID.
What do you believe would be the most important steps that we need to do right now to prevent a future H5N1 pandemic?
There's so many steps, but let me focus on one. So genomic surveillance is very, very important. And what that is essentially getting samples and figuring out how the virus is evolving and doing that very quickly, and being able to figure out when the virus has certain mutations that would make it more likely to transmit in humans and between humans. That is essential. Where we are limited is that when you rely on testing where you have to go and swab people and test people, many of these farms and farmers have been hesitant and reluctant to even get tested. So what that means is we're now reliant on potentially environmental surveillance, meaning like sampling the air in the farms, sampling wastewater that is coming out of farms. So wastewater was surveillance really picked up during COVID. That's where we test wastewater to figure out how much virus, what type of virus, where is it coming from. And that doesn't rely on, going and swabbing people's noses or getting blood samples. It just relies on getting wastewater. So there are some very promising technologies that have been demonstrated to already work. My colleagues and I have a publication coming out in The Lancet very shortly that kind of discusses one aspect of this. But getting surveillance where you can actually get the sample from the wastewater, and you can figure out if the sample has certain mutations that would make it seem more likely or a higher risk for adapting into humans and transmitting between humans. The future, I think, is going to be a different one where we have much better detection of viruses in the air. So the U.S. government already has a program where they're trying to get they're funding proposals to have better air sensors for detecting pathogens in the air. And then there's obviously the big wastewater work, a lot of which actually is done at Stanford through Ali Beam's group and Wastewater Scan. And Verily. So that environmental surveillance and genomic surveillance is huge. It's like a very, very key aspect of pandemic response. And I think it could be really what prevents this from getting out of hand if we can scale up some of that tech, because our traditional epi methods of testing people, they're not fast enough and they rely on people really complying. And, that's really not a dependable strategy.
Thank you, Dr. Karan, for taking the time and sharing your valuable insights on the H5N1 virus. And I'm sure that as we learn more about the topic, and there will be many opportunities for more conversations on this and much more updates. So it has been a pleasure learning from you directly. And so thank you once again for your time and your expertise.
Yeah, thanks so much.